So number one, if I can get into the true lumen, I think it's very risky to try to advance cutting into the false lumen and try and go backwards into the true lumen. So my approach would be try your darndest to get into the true lumen. And fortunately, the situation where when we need to use cutting lumens are basically type 2s and type 3s. Mostly type 2s, because you don't have physical disruption. If you're type 1, usually you don't have a lot of injuries hematoma. So I don't think cutting lumens would be useful in type 1s, right? So it's really the type 2s, really bulky hematoma, reclusive lesions that's useful. Unfortunately, in those cases, the presence of physical disruption is really not quite there, right? So it's easier to write a true lumen and use the small lumen units in there.
Yeah, I guess I was thinking that you could tear it from the inside or the outside.
You could tend to,
really
my fear,
to get holes.
yeah, but my fear is if you're in a false lumen and you tear, you might actually perforate.
You might, but I mean, we wrote it in the subdivisional space.
You're a lot more brave than I am.
Yeah, we're done, right? You know, brave or stupid. So, speaking of brave or stupid, I would like to introduce.
Only surgeon.
I don't even know you. I'm so sorry. It just seemed like an appropriate surgical introduction. So, Dr. Price looks like a very nice plastic surgeon from UBC, and I always am so happy to have cardiothoracic surgeons at our talks. And this is a broader talk, but we're often at interventional conferences, and it's a bunch of interventionalists, and so I always think they're very brave to come. So anyway, please come up and talk to us about average in these patients. Thank you.
Thank you very much for that interesting introduction. I appreciate the opportunity to speak in front of this audience today, and yesterday when I confirmed with Jackie about speaking today, she was quick to point out that I'm the only surgeon invited on the panel, and I do consider that an honor, and Dr. Tremble actually has, her comments were demonstrative of the point that I'm about to make, and that is that it is an honor because I know that the general public and my cardiology colleagues in particular view surgeons with sort of equal parts of reverence, fear, and disdain. So having said that, I keep that in mind when I give this presentation. So my task today is to discuss the role of coronary artery bypass grafting in SCAD, indications, strategy, and outcomes. I have no relevant disclosures. So my approach today will be, first of all, to review the data. Now, fortunately, my colleagues have made this an easy task. It's been reviewed in great detail already. I'll try and point out some of the salient features. We'll discuss then indications. I'm going to discuss outcomes before strategy and approach, and that the reason for that, although somewhat atypical, will become apparent when I get to it. No cardiac surgeon, as the data we have seen today demonstrates, has significant technical experience with operating on patients with SCAD. However, myself, I am primarily an aortic surgeon, so I do have some experience with operating on dissections of another type. This histopathological specimen is not, in fact, a coronary artery, but is an aorta, and this is where I spend a great deal of my time. So, I believe it was Dr. Tremble again who pointed out that surgeons are rarely hesitant to do anything, so why is it that we would hesitate to do CABG, which, by the way, is the most common operation myself or any of my colleagues perform? Why should we be at all hesitant to do this specifically in the situation of SCAD? And this is meant to be demonstrative of the reasons why. As has been explained, Dr. Fung was pointing out that dissections, whether it be in the aorta or the coronary artery, involve shearing of the media, within the media, so you're left with an intimomedial flap and an adventitial medial flap. In any case, you're left with extremely fragile tissues, and dissected tissues in many cases. And I can tell you from operating on many dissected aortas that that is oftentimes an unenviable task. The next reason why we hesitate is related to the demographics of the patients that do present to us with this disorder. This this table is from one of the earlier publications from the Mayo Clinic group. And what I'm intending to highlight here is if you'll look at the incidence of connective tissue disorders in this population, particularly, so we'll see here Ehlers-Danlos, fibromuscular dysplasia, it's an extraordinarily high, if you look at the incidence of these disorders in the general population, they're extremely low. But in this population, they're making up somewhere to 20 to 30% of the patients. And again, from operating on aortas in patients with these disorders, the tissue can be extraordinarily fragile. So, as surgeons and as cardiologists, we like to inform our practice whenever possible with data. However, as has been highlighted by a number of our previous speakers, there are issues with the data related to this disorder because of the relative rarity of this disorder and the relative inexperience with interventional cardiologists and surgeons in treating this disorder. So many of the issues with the data have already been highlighted. I'm just going to try and point out a couple statistical nuances to the data and how they pertain to surgery. So this is pulled from one of Dr. Saw's publications. And the first point I want to highlight is the surgical experience, and the PCI experience, but certainly more so with surgery, is extraordinarily limited. So at that time in 2014, the Vancouver experience involved 168 SCAD patients. And in all of those SCAD patients, only 38 were intervened upon, and of those 38, only 5 underwent CABG. So in absolute numbers, there is a very, very small global experience in the hands of cardiac surgeons with SCAD. And that's reason for concern, and it also limits our statistical power to draw any meaningful conclusions about approach, indications, outcomes. The next major issue with the data is selection bias, and I'm going to elaborate on this a little bit if you'll permit me. This is from another Mayo Clinic paper where at the time their series with 87 patients, they were a bit more aggressive. This is somewhat older data, so that's probably reflective of the time at which it was published, but they were a bit more aggressive with intervention. But again, you see the CABG patients are in absolute number, are far fewer than PCI patients. So the message that should send to the discerning viewer is that the patients who went to CABG were highly selected. If you look at this example, and this is true in many of the series, including our own here in Vancouver, a few of the patients were referred off the bat for CABG, but more of them were rescue CABG. So that should say something about the type of patients who ended up going to CABG, but moreover, it is very difficult to adjust retrospectively with techniques like we mentioned, propensity score matching or time to event analyses. Selection bias can be extremely difficult to adjust for. And the type of selection bias we're talking about in these data is a very specific subset of selection bias, and that is called confounding by indication. And what that means, that's what I just tried to point out, is the fact that the differences in selection of these patients is how they came to have the procedure in the first place. So they are selected on their indication for the procedure. And again, that's a very particular form of selection bias that's difficult to adjust for. This is the Mayo Clinic series updated to 2014, and the reason I chose this is to point out, if you look at the ratio of CABG to PCI, so 6 CABG for 87 PCI, these CABG patients, so the interventional patients were highly selected in the first place, but the CABG patients even more so because the ratio is so skewed towards PCI. So again, all these statistical issues limit our ability to draw conclusions because of limited statistical power and the type of selection bias called confounding by indication. So having said all that, we have to work with the data such as they are. I'm going to make a couple of points that have already been made very well by previous speakers, and that is that this disease, generally speaking, has a very favorable natural history. This is from the Vancouver series published again by Dr. Saw in 2014, and the point I want to highlight here particularly is that when these patients are imaged late, a very, very high number of them heal spontaneously. And I want you to keep this point in mind because it will inform our surgical approach later. So, indications. We have to take these data and try and form some surgical indications. Jackie published her initial algorithm towards the indications for intervention, both PCI and CABG in 2014. In very brief terms, and again, this has already been covered, that the only time we tend to intervene on patients is when the presentation is complicated. And among those complicated patients, we have to try and distill out who will be best served by PCI versus CABG. So this algorithm was a bit further refined in Dr. Saw's 2016 publication. So to summarize this, the graph as best possible, that if a patient is stable and uncomplicated, we do not intervene, again, because of a very favorable natural history. If the presentation is high risk, and high risk can take two forms. Ischemic, are they having chest pain, are they having STEMI? Then we have to think about how to best treat them with an intervention. Or if they're non-ischemic but they have an extremely large territory at risk. The classic example of this is left main. I think Dr. Trumbull went through this algorithm in some detail. I have nothing further to recommend. I do think this is a very reasonable and as much possible data-driven approach to the indication for intervention, and particularly coronary artery bypass grafting. I think that in general, if you're pushed to intervene and the patient is at all unstable, be it ongoing chest pain, STEMI, VF, shock, PCI has the advantage that it has also an atherosclerotic disease with STEMI, and that is the ability to intervene quickly. Dr. Saw mentioned that it takes time to get the patients to the operating room, and even once I get to the operating room, this critical, as you guys well know in the STEMI literature, the critical variable is time to balloon or time to revascularization. The time to the OR is not our time to revascularization. It takes time. I have to be able to open the chest, I have to harvest conduits, and I actually have to be able to sew the grafts. So our time to balloon or time to revascularization in this case would be dramatically higher in acute presentations than PCI. And for that reason, the algorithm recommends PCI in the unstable patients. So that leaves a very small group of patients in whom CABG is recommended. And the most reasonable example is exactly what Dr. Saw mentioned, and that is a stable patient with a very large territory at risk. So based on the data such as they are, I think that's a very reasonable indication for coronary bypass grafting in this population. This is just summarizing what we've just discussed. I won't go through it again for reasons of time. So we talk about when something is amenable or feasible, and this becomes quite a technical discussion. Allow me to just distill it down as best possible. Actually, I'm quite grateful, despite the introduction, quite grateful to Dr. Trumbull. She actually did most of my work for me. That summary you gave of the pros and cons of CABGs and the technical challenges of CABGs was extremely accurate. I'm surprised you're not a surgeon, but it was very easy to make my job much simpler. We have to select vessels that we can graft, and for those of you who are unfamiliar with coronary bypass grafting, what's involved is opening a vessel with a knife, with this small scalpel, getting into the true lumen, and being able to sew by hand with a very fine polypropylene suture a conduit, be it an artery or a vein, to that vessel and allow flow through it. That is coronary bypass grafting in a nutshell. And I often, when consenting my patients for CABG, I always explain and introduce myself as basically a fancy plumber, because that is in fact what I am. So in general terms, we've gone through the subtypes of SCAD. Type 1 generally is amenable, type 3 is amenable, type 2 can be challenging, but this even is an oversimplification. Really what we need to try and discern when looking at the angiogram, so if I'm sitting with Dr. Saw, is in the areas that I can graft, the vessel has to be big enough for me to graft, is it dissected there? And if so, do I really think that I can get a reasonable result? Again, that's where the lack of experience, both in my hands or anyone else's, becomes a problem, because I don't have a great deal of any coronary surgeon in grafting these vessels, but it can be technically challenging for the reasons that Dr. Trumbull explained. So what are the outcomes? This is a paper published by the Mayo Clinic group that looks specifically at the outcomes of intervention. When they examined the CABG data, there's a couple salient points that I'd like to highlight. Number one, the early mortality, relatively speaking for CABG, is high, but the long-term mortality of the survivors is extremely low. And that speaks to the nature of the disease. Why is the early mortality high? So when I quote the early mortality risk of CABG for atherosclerotic disease, I quote a risk of approximately 1%. In this hospital, it's even lower. The reason for that is because of that selection bias, that confounding by indication that we discussed earlier. The patients who come to us with CABG, historically, not with the new algorithm that Dr. Saw has proposed, but historically, these are patients who have failed PCI, and they're coming to us for possibly a rescue, that is a high mortality group, and therefore it's a high risk. I'll point out though that there are only 20 patients in this group, so again, very limited statistical power. The 0% 5-year mortality, that would be unheard of in an atherosclerotic population. The reason for that, again, as has been previously explained, these patients for the most part heal, so therefore they have a favorable long-term natural history. And last but not least is that more than 2/3 of these grafts will go down. Again, this has been previously explained. The reason why is these patients heal, and they develop a phenomenon known as competitive flow. The patency of bypass grafts relates to the ability to have high flow and a good outflow territory, and we'll come back to that point in a following slide. From the same Mayo Clinic paper, they demonstrated that in general, for the patients who survive, revascularization and conservative therapy have similar outcomes. That's over their 5-year follow-up. We'll get back to this point of the grafts failing. So we mentioned this, but as Dr. Trumbull pointed out, this is not a failure of CABG. This is actually how the operation is designed. So there is a paradox between the patency of grafts and the long-term survival. In general, for atherosclerotic disease, which is the vast majority of these CABG patients, we believe that the long-term survival of these patients rests upon the patency of the bypass grafts. And that is intuitive if you think about it, that if the bypass grafts are open, these occluded vessels are being perfused, and therefore the patients continue to survive. But SCAD, because the pathophysiology is so different, those of you who are familiar with surgical therapy for heart failure will be familiar with the bridge to recovery or bridge to transplant, the bridging concept. And what that means is there is a modality by which you keep a patient alive until a more definitive thing can happen. In this case, that definitive event is the healing of the vessel. So the only role of bypass surgery in these patients, for the most part, is to keep them alive with good coronary flow until such point as they heal, which is what happens in most patients. So this is a bridge to recovery. And this phenomenon is what informs our surgical technique. So that's where we will, this is the reason why I delayed strategy and approach till the end. Point number one I would like to make is that we should in general avoid attempts to graft dissected tissues. That's why type 2 in particular, with the very long dissected segments, can be problematic. Grafting dissected artery is not easy. And again, I know this from the aortic population, but aorta, generally speaking, are 4 or 5 millimeters in diameter, 4 or 5 centimeters in diameter when I operate on them. Coronaries, a big coronary is 2 millimeters. So the technical difficulty is compounded by the very small size of coronary artery, trying to distinguish true lumen from false lumen, trying to work with literally paper-thin tissues. Actually, paper would be quite thick in comparison to what we deal with here. So grafting dissected arteries is extraordinarily difficult, if not impossible. There is no clear superior strategy based on data. We talked about the limitations of data. However, as Dr. Tremble again very astutely explained, arteries in general, so there is a histopathologic difference between arteries and veins. Arteries have a muscular media, a mid-layer of the vessel, as opposed to veins, which essentially do not. That muscular media will respond to competitive flow. So if there is a lot of flow through the native vessel because it is healed, and not a lot of flow through the graft because it's being competed with through the native vessel, that muscular media will spasm down and essentially cause functional occlusion of arterial grafts. That phenomenon of competitive flow is far less important in vein grafts because of the lack of a muscular media. Therefore, in general, we recommend venous grafts, again, because they will be the most effective bridge to recovery. However, there are in the data people using arterial grafts. You could use on-pump, off-pump. None of that matters. There are no data to support it. You should do what, in the hands of the surgeons, is a comfortable, safe, reproducible technique. We talked about the mortality patency paradox. Again, the goal here is to achieve survival, not with long-term patency of grafts, but as a bridge to recovery. And again, as I said, a safe strategy certainly is high-capacity venous grafts that have high flow in the immediate setting right away, as opposed to arteries, which sometimes have low flow at first and they require some maturation. And they're far less sensitive to competitive flow because of the absence of a muscular media. So I'll just summarize very briefly with some conclusions. CABG in relative terms is not often necessary in the management of SCAD. As a general rule, it's when either PCI is not possible or when there is a very large territory at risk, and CABG outcome is excellent despite or because of long-term graft patency being poor. I talked about the challenges, abnormal fragile vessels. We talked about the statistical concerns, the favorable natural history, the bridge to recovery, and I just want to make another point. We talked about the advantage of PCI being a rapid revascularization, but in most cases, not all, but in most cases, if PCI fails, we do have CABG available as a rescue therapy. The survival is excellent, despite graft patency in the long term being poor. A safe technique, and again, I choose those words cautiously because of the lack of data, but certainly a safe technique is to use venous grafts because of their ability to provide high flow immediately without being threatened by competitive flow. Thank you very much.